Hello, my name is Sunny, and I'm a registrar in infectious diseases. In this video, I'll be talking to you about VTE, venous thromboembolism, in the context of COVID-19, and the current recommendations regarding VTE prophylaxis at Cambridge University Hospital Trust. Please be aware that if you've moved from a different trust or a hospital within the same trust, the VTE guidelines may differ significantly as they've been partly based on expert opinion. This video was recorded on the 10th of January 2021 and provides up-to-date information for this time point. However, if you're watching this video a number of weeks down the line, please make sure that you log onto the CUH portal and look for the latest version of VTE prophylaxis guidelines to make sure that you're up to date. So why are we talking about VTE? Patients with COVID-19 are at an increased risk of both arterial and venous thrombosis. So VTE is a recognized complication of COVID-19 infection. During this talk, we'll be focusing on recognition of PEs in particular, as they're potentially life-threatening. However, as clinicians working in red wards, we need to remain equally vigilant to the early recognition of DVTs. So how do we diagnose a PE in the context of COVID-19? Unfortunately, in many cases, this is not straightforward, as there is significant overlap between COVID-19 deterioration and PEs. So it requires careful history taking and clinical assessment, and particularly if you're relatively junior in your role, you should not hesitate to escalate and discuss with your seniors if in doubt. Earlier in the video series, we discussed the trajectory of COVID-19 related deterioration. It can happen rapidly, but typically it presents with a progressive increase in oxygen requirement, and that is mirrored by worsening chest X-ray findings and also worsening findings on auscultation of the chest on clinical examination. If a patient does not fit these criteria, or if the deterioration is sudden, consider alternative diagnosis, including PE. So, step number 1, think about whether it fits the trajectory. For example, if a patient is maybe day 20 of COVID-19 and was doing well, weaning on oxygen or maybe a couple of liters of oxygen, and suddenly deteriorates from a respiratory perspective, consider whether PE might be the cause of this. Also, ensure that you get up-to-date imaging in the form of an up-to-date chest X-ray. If the chest X-ray is clear, it increases your suspicion of PE. Finally, remember that there are other symptoms that might increase your suspicion of PE. Remember to ask about chest pain, particularly pleuritic chest pain. Look for sinus tachycardia that is persistent, particularly if it's occurring outside of periods of high fevers. And look for other thrombosis, because if a patient already has a DVT, you should have a very high index of suspicion for PE. How do we investigate PEs? The investigations in COVID-19 are much the same as you would undertake for any patient on the medical take. Get an up-to-date chest X-ray and ECG as discussed, and also you would send a D-dimer. The interpretation of the D-dimer, however, is more nuanced in COVID-19, as the predictive cutoffs have not been validated in COVID-19. Therefore, the results have to be interpreted with care. It is nonetheless a useful and important tool in your arsenal, and it remains true that a very high D-dimer is associated with the increased likelihood of PE or DVT. Of course, the other investigation, which is the gold standard for looking for PEs, is a CTPA. But you should consider the correct timing for a CTPA. By this, I mean, is the patient stable enough for transfer? For example, if a patient deteriorates in the middle of the night, it may be more appropriate to start empirical anticoagulation if there are no contraindication to this, and organize a CTPA in daylight hours with more appropriate cover. But we know that prevention is better than cure. So what should we be doing from a VTE prophylaxis standpoint? If you're working on the wards, all medical patients should have the standard normal VTE risk assessment, and the prescription of prophylactic dalteparin. There is no change due to the diagnosis of COVID-19 infection. Remember, dalteparin should be appropriately weight adjusted and renally adjusted. But for the vast majority of patients, for example, for somebody weighing 70 kilos with a normal renal function, they would receive 5,000 units once daily. If a patient is in intensive care, or if you yourself are working in intensive care, however, VTE prophylaxis has been increased from standard. This is because the incidence of thrombotic complications in ICU patients with COVID-19 infection was shown to be in excess of 30% despite standard thrombosis prophylaxis in early case series. Therefore, a pragmatic decision was made to escalate to an intermediate dosing regimen for prophylaxis on intensive care. So for the same patient weighing 70 kilos with a normal renal function, they would be receiving 5,000 units twice daily instead of once daily. When the patient is stepped back down to a lower dependency unit, so coming from ICU back onto a medical ward, the VTE prophylaxis should be updated and the dose adjusted to be in line with that of the ward medical inpatients. So when patients move from one context to another, we should be reviewing and reducing the dose appropriately. Another change related to COVID-19 is that VTE prophylaxis is recommended for 7 days after discharge. This can either be prophylactic dalteparin or rivaroxaban at the lower dose, 10 milligrams once a day for the 7-day period. If patients have severe renal impairment, so a creatinine clearance below 30, rivaroxaban is contraindicated. In these patients, you can either use renally adjusted doses of dalteparin or alternatively apixaban at the correct dose adjustment. If a patient has severe renal impairment, so creatinine clearance below 15, or a patient is on dialysis, we recommend that advice is sought from the renal or hematology team prior to discharge. Also remember that as you're starting a patient on a new anticoagulant, even though it is for a short period of time, patients need to be appropriately cancelled. To help with this, there is an excellent patient leaflet that's been created by our pharmacy team that is available through the CUH portal on Merlin. The final group of patients we need to consider is patients that are discharged directly from ED or from other assessment areas such as N2. In these patients, prophylaxis should be considered if there's any concerns about mobility or if there are additional risk factors other than COVID-19 that would increase risk of VTE. Please remember that when you're prescribing anticoagulation, you should be considering bleeding risks. So all the recommendations above are guidelines and should be treated as such. It is important that we take a full medical history from the patient and also look at the concomitant medications, in particular looking for any antiplatelet agents such as aspirin or clopidogrel to assess for the risks that come with starting anticoagulation. As an example, if a patient has been admitted with a recent large GI bleed and then re-presents to hospital with a relatively asymptomatic COVID-19 infection and no reduced mobility, it may be more appropriate to withhold anticoagulation on discharge rather than send them home with 7 days of rivaroxaban. So what should we be writing in our discharge summary? It's important that the indication is clearly stated. As we've been discussing, PE is a major complication in patients with COVID-19. So what we do not want to happen is for somebody who has had a diagnosis of PE whilst in hospital to have the anticoagulation stopped inappropriately because it's thought to be prophylaxis. So indication is key, and hand in hand with that goes dosing. The dose of rivaroxaban should be clearly stated, whether it's prophylaxis or treatment. And finally, the duration should ideally be written in the discharge text as well as the medication reconciliation, with a clear indication to stop after 7 days. On the flip side of this, If a conscious decision has been made by the medical team not to start anticoagulation, the reason for this should be documented, as it will help any colleagues should the patient represent in hospital. So in summary, the key messages to take related to VTE and COVID-19 is to think about VTE, think about Ps and DVTs. Make sure that you prescribe VTE prophylaxis for all patients with COVID-19. And depending on where you work, use the escalated intermediate dosing for intensive care. Finally, patients should, by and large, be discharged with anticoagulation for 7 days unless there is clear contraindications. That's the end of my talk. I'd like to thank you in advance for all the help that you'll be providing on the wards, and I look forward to working with you shortly. Thank you very much.